Hi, this is Brian Kim. I'm going to share with you this patient with a very cloudy cornea, and I'm going to show you my strategy as far as how I handle this situation to perform cataract surgery as well as a DSAEK corneal endothelial keratoplasty. So this is the patient's cornea. You can see the view is quite cloudy, and I realize there's just no way I'm going to be able to see through that cornea. So I use a cotton tip to see if I can peel off that epithelium, but that didn't work. So I'm using a crescent blade and using the cotton tip to carefully hold the eye still. I'm peeling off the epithelium almost like a rhexis technique with the crescent blade. So go ahead and remove that epithelium, and you can see how much clearer that view is into the anterior chamber and the lens. So now I can feel like I can do this case more routinely. Now this is a cool thing. I'm going to do this technique where I make a stab incision starting mid-peripheral and then tunneling and entering into the anterior chamber in a more peripheral location. And so that's my technique when I do DSAEK, because I'm able to place fluid and air with that technique without disrupting the attached Descemet's tissue. So I'll go ahead and make the rest of my incisions and inject some intracameral lidocaine and epinephrine, and then some dispersive viscoelastic. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, rotate the eye towards me, and then I enter. Push some more viscoelastic in. And these are the Haldey-Perkar capsular rhexis forceps that go in with the teeth sideways. Try to puncture the center, which I'm able to do. Pull down towards me, creating a tear, grabbing the right side of the tear. And because of the forceps, I have really good control. They open nice and wide. I'm able to grab. I have minimal viscoelastic egress, and I do the technique. I don't have to keep pulling centrally. I'm using the corneal mark that I made as a guide to help me center and size the rhexis. And since I'm doing a DSAEK, you want to have good overlap of the rhexis and over the optic. This is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, decompress on the left side, and the lens begins to spin on the right, hooking the peripheral lens. I'm irrigating the surface of the eye, adjusting my sleeve. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material. Placing the chopper under the rhexis edge contra-incisionally. The phaco tip vertically sub-incisionally. Crushing and bisecting the lens in half. That's double chop. Placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, fracturing the right heminucleus. That's cross chop. Using some vacuum to lift that first quadrant up. Crushing the lens between the instruments, and then emulsifying the lens pieces. Placing the chopper around the second quadrant and performing another cross chop maneuver. So even though the view is better, again, keep in mind it is still a cloudy cornea. And so the benefits of double chop, cross chop, and mechanical fracturing is I'm not having to blindly go in with the phaco tip to try to grab pieces. So when it's hard to see and hard to pull up pieces, the tendency is to try to grab it with the phaco tip with vacuum. That is the last thing you want to do, because if you're not careful, that vacuum will grab the posterior capsule and you'll have posterior capsule rupture. And so by using the chopper, it's a much more controlled way. You can't really grab the posterior capsule or snag it with the chopper because you're chopping really between the epi and endonuclear interface. And so I'm able to hook the lens pieces around and with the chopper and crush it between the instruments, lift pieces up out of the bag. It's a very controlled way of doing lens disassembly in situations where you have less than ideal visualization. So as I was talking, I believe most of the lens pieces are out. I think this is the last quadrant. So you want to push down on the lens as you go out around the lens piece. You saw I crushed the lens between the two instruments using some vacuum to lift that piece up. It was already loose, so I don't have to go deep into the bag with the vacuum. That's what you don't want to do, is go deep into the bag trying to grab lens pieces when you can't see. So I'm grabbing the anterior edge of the epinucleus and it starts to tumble out, keeping the chopper deep to protect the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out, go in with the INA handpiece, start sub-incisionally removing the cortical material from anterior to posterior. It starts to peel quite nicely here. This pupil is not a great pupil as well, so you want to be mindful that you don't grab the pupil also. Switching to polish mode, especially when you don't see us well, you want to switch to polish mode. It's going to be less traumatic to the bag and the zonules. Normally, I pulse the subincisional space with BSS, but because the view is limited, I just go straight to the cohesive viscoelastic. I'm going to widen the incision with the blade. Normally, when I do DSAEKs at the same time of cataract surgery, I want to make sure I have a nice, stable lens, and so I usually place a three-piece lens in this situation. Doing a triple DSAEK case, again, I like to use a three-piece lens instead of a one-piece lens, because when the chamber collapses, the three-piece lens tends to stay in the capsular bag plane, whereas a one-piece lens might try to prolapse up out of the bag. I'm using the Maltzman to make sure that leading haptic is in the bag, and then I go ahead and deliver the leading haptic in the bag, and making sure the optic comes out planar, and then using the Maltzman to dial the trailing haptic into the bag. So I'm making sure that the corneal surface is dry with the Weck cell, and then I have a pre-marked free tree fine. It's about 8.2 millimeters, and it's been marked, and then I try to mark the cornea in central fashion, and this is a reverse Sinskey hook, scoring along the edge. I like to stay inside a little bit, score about 8 millimeters instead of an 8.2 diameter. So there's a little bit of overlap between the patient and the donor. As I'm scoring, start to try to tease off the stripped edge off the cornea. As you see there. All right, so I was able to tease off the diseased descemes and endothelium off the cornea. Go ahead and pull it out. Go ahead with the INA, removing all the viscoelastic from within the bag, going underneath the lens, and then the anterior chamber, placing the Lewicki AC maintainer. You can see the position is going from mid-peripheral out to the far peripheral. These are the forceps through a contralateral incision with the boost and glide in forceps. Tissue has been pre-placed on the boost and glide, pulling the tissue in with the boost and forceps into the anterior chamber. Fluid is activated at this point, making sure when I loosen my grip with the forceps that the tissue has been released. Activate infusion and tissue begins to open up. I like to turn off infusion here and then place a tendonylon suture through the main incision. You don't want to be gaping the incision and having infusion active. You don't want the tissue to try to come out. Go ahead and tie that knot. And I'm removing, there's some bubbles in the interface. I want to make sure there's no viscoelastic between the patient's cornea and the tissue. So I like to flush with some BSS, and this ensures there's no viscoelastic that might interfere with the adhesion of the tissue. I bend this 30-gauge needle mounted on air. The needle is used to hook the tissue peripherally, and then I inject air, and then I can position the tissue in central fashion using the hook of the needle. And then I use a cannula to inject some more air through a peripheral incision. Take the AC maintainer out. That's a 23 gauge. In this case, I was lucky and I was able to get a really nice position without having to keep manipulating the tissue. I'm using the Wexel to push down on the cornea and massaging any potential liquid interface. I do a 10-minute dry time, and so you don't see that here. So 10 minutes have elapsed, and then I'm using a straight needle with BSS. I'm doing an air fluid exchange. With that incision, since I started mid-peripheral and then I enter the anterior chamber far peripheral, it clears the tissue, it doesn't touch the tissue. And by doing it this way, I'm able to really get consistent, easy positioning. I'm able to titrate the BSS and the air bubble quite nicely. I don't want a full air bubble at the end of the case. I really want about an 80% air bubble at the end of the case. So I get the bubble that I like, and so I go ahead and inject some intracameral antibiotics and steroid, and this is the end of the case. So again, difficult view, complete epithelial edema. You can peel the epithelium off and be able to successfully perform cataract surgery and DSAEK surgery. And in the case of poor visualization, performing double chop, cross chop mechanical fracturing techniques is really a very safe way to disassemble the lens when you have a compromised view through the cornea. So I hope this was helpful to you, and I thank you for your attention.